Good morning, everyone. Thank you for joining the conversation. My name is Rebecca Robbins, and I am a San Francisco-based reporter at STAT. If you're not familiar, STAT is a digital news organization covering the worlds of health, medicine, and life sciences. And our subject today is the clinic visit and how it's poised to be transformed by enormous amounts of data. It's a transformation that creates the potential for huge benefits in how patients get their care, whether that means more effective and personalized therapies or just a better care experience. But the transformation raises tough questions too, that everyone in this space is going to have to think about. Some of them are, how is the physical infrastructure of the clinic going to have to change to accommodate these new technologies? There's also questions about data. Who controls and who owns all this information? There's also questions around hiring. What kind of skills are companies and healthcare providers going to have to prioritize as they think about building the workforce of the future? And what other kinds of obstacles are going to make these problems hard to solve and the promise hard to realize? So to talk about all of this, we've got a great mix of folks here today from different parts of the healthcare ecosystem, including therapeutic development, primary care, care of veterans, and the investment side of things. So I want to begin by briefly introducing each of our panelists and giving them a chance to speak to the question that they are trying to answer or solve. So on the far left is Deborah Scheer. Deborah works for the U.S. Department of Veterans Affairs, where she leads the Center for Strategic Partnerships. She provides guidance to the VA Secretary on public and private partnerships. So Deborah, could you explain for us, what is the question you're working on?
So the question we're working on is how to provide the best level of care to the 9 million veterans we serve in this country. How to make it accessible to them, convenient to them, and also give them state-of-the-art care as a government partner. And to do that, part of why we're here today is because we know we can't do that alone. So one of our big questions is, how do we most effectively partner with all of you, with industry and foundations? Because we know there are things that government can't do by ourselves. Thanks, Rebecca.
Next on my left is D.A. Wallach. D.A. is managing partner at Inevitable Ventures. He is an investor who is primarily focused on the life sciences since 2015, but he's also a man of many talents, including as a recording artist, a songwriter, and an essayist. So, D.A., tell us what problem you're trying to solve as you think about investing in the life sciences.
Yeah, so broadly speaking, we try to invest in this next generation of medicine, which I think is pretty well encapsulated by the rhetoric around precision medicine. We're essentially moving into an era of personalized, preventative, and curative approaches. And we believe that the clinical application of that new type of medicine will be pushed by the sorts of next generation biomedical products that folks like John are helping to develop in industry. And so commercially, what we're really focused on is financing a next generation of inventors who the capital markets don't currently serve in a sufficient way. And so we basically day-to-day look for really interesting early stage science in academia and really talented young entrepreneurs, and then we try to give them both the money and the external development resources that they need to bring their vision into the market.
Right here we have John Tsai. He is the head of global drug development and chief medical officer at Novartis. He has previously had stints at drug companies including Amgen, Bristol Myers Squibb, and Pfizer. John, tell us, what is sort of the core question you're working on trying to solve at Novartis?
Yeah, thanks, Rebecca. There's many questions that we're trying to solve, but the main one that we're looking at is, how do we continue to improve the healthcare of individuals around the world? So I take a step back, and if we actually think 100 years ago when the FDA started, we only have actually discovered about 1,500 drugs. And in fact, there's so many diseases that are still out there, and we continue to advance. And I think it's the perfect timing in terms of the convergence, in terms of advances in digital technologies, as well as advances in science and understanding of the human biology. And I think over the next 10 years, we're going to see some significant breakthroughs in terms of disease understanding, and as well as treatments and how we attack those diseases.
And then on the far right, we have Jenny Vargas. Jenny is Chief Strategy Officer at One Medical. That's the membership-based primary care practice. And Jenny works on payer relations and strategy, as well as employer strategy and partnerships at One Medical. And before joining One Medical, she was at Stanford Healthcare. Jenny, tell us what core problem you're thinking about trying to solve at One Medical.
Thank you. Well, what a great panel to be discussing all of this. We're really trying to make healthcare more engaging and accessible. And we focus our primary care efforts on doing that, and we do it by offering same-day appointments, less than a 2-minute wait time in the office, 24/7 virtual coverage, and very warm and friendly providers. Because we believe that the doctor's office of the future, much like the doctor's office today, has two parts: an in-person, trusted relationship with a provider, and then a constant 24/7 virtual access to a team that can help you with any of your medical problems. And we tend to look at primary care very broadly. We take care of your everyday health needs, chronic illnesses, and behavioral health, because that's such a prominent issue in our population today.
So I want to, for sort of the first discussion point, throw this question back to Jenny and talk about telehealth and telemedicine, which I think is sort of a key part of how the clinic visit is already beginning to change. What do those visits look like? How do you sort of think about the difference between in-person visits and telehealth and telemedicine?
Yeah. Well, first of all, I love the name telehealth, since no one uses a home telephone anymore. But anyway, we call it virtual or digital health. But really the way we work is you can get on our app, and of course everything is app-based nowadays, and you can schedule a visit, an in-person visit this afternoon, or you can just click and have a video visit instantly. We've seen we've been around for 11 years, but we've only in the last couple of years seen a dramatic uptick in our video visit usage. And I think that's everything from convenience to people know us well enough now that they feel comfortable that we have their full record, electronic medical record, which we developed and have there. We have all their prescriptions, their health history. So if they get a virtual medical team member, not their normal primary care doctor, they can just look at their record and help them with whatever is bothering them, including, I don't know what to do about this prescription that didn't get filled at the pharmacy, or I didn't get the appointment I wanted with a specialist. We'll help you with that 24/7. We'll also allow you to message us. So there are many ways to interact. So I think telehealth is the sort of label we put on it, but we're going to see this explosion of virtual interaction, meeting the patient where they want care and help.
And so the VA is thinking about telemedicine and telehealth as well. What's your perspective on bringing this kind of care to veterans?
Well, thank you, Rebecca. I mean, we're more than thinking about it. The VA actually leads the nation in telehealth. We did over 1 million video visits last year. We serve, out of the 9 million veterans we serve, more than a third of them live in rural areas. Many of them have to drive great distances to get care. Many of them have caregivers who want to participate in those sessions. Many of them have family members who don't live in the same place that they live. And so telehealth has been, particularly video telehealth, has been a very, very powerful tool for the VA. And we're using it not just for the things that many of you, I mean, this is interesting. How many of you have had a telehealth visit? Okay, so it's starting, but not that many, right? And at the VA, we're using it not just my child has a fever, my child has a sore throat. We're using it for people who have had spinal cord injuries who can't get in a car and drive. We're using it for derm visits. We're using it for group therapy. We're using it for music therapy. We're using it for physical therapy. We're using it for nutrition counseling. I mean, we are truly building a community around virtual care. And one of our big strategic questions is, telehealth started as kind of a silo off to the side. Okay, this is for people who can't get to their appointments. But it's truly become embedded in the way we deliver care. And so what does that look like in the future? And when we get to brick and mortar, I'd love to talk about where we're going with our healthcare footprint.
And speaking of brick and mortar clinics, I want to ask John, Novartis is of course working on innovative cell and gene therapies, the kind of therapies of the future that in many cases require a very different physical infrastructure to deliver those kind of medicines. What does that look like? And how is Novartis thinking about sort of linking up the physical infrastructure of a clinic with the new medicines that you're working on?
Yeah, thanks, Rebecca. And the way that we think about approaching drug development in terms of digital health is that we know that this landscape is changing very quickly in front of us. And in fact, we've started what we call decentralized clinical trials. And in fact, in the US, when we look at recruitment into clinical trials, only 3% of the population that wants to be in clinical trials are involved in clinical trials in the US. In Europe, it's only 5%. And we have a hard time recruiting patients for many of our clinical trials, such as in oncology. And there are so many patients that are out there. So what we've started to do was we started to look at how do we actually conduct clinical trials that are actually out in remote areas where you don't have to drive, 5 hours to see your physician. So those are some of the advances that we're beginning to make in terms of making sure that we can actually move these clinicals faster so that we can develop drugs much faster for patients so we can find solutions to these problems.
Great. And I want to also ask DA, from the perspective of an investor, how do you think about healthcare delivery infrastructure and opportunities there?
Well, I think the delivery infrastructure in some ways is the part of the system that's hardest to innovate in, because that's where this hornet's nest of perverse incentives keeps things so sclerotic. I think a lot of the public outrage, you guys may be glad to hear this, is misplaced on the pharma companies and on the insurance companies. And if you look at it from a dispassionate financial point of view, although most of the profit is in the sale of branded pharma, most of the spend by far is on providers. And so my view would be that the hospitals are really the biggest problem, at least in the US, maybe the VA accepted.
Thank you.
And if you look on paper, it doesn't look like these are great businesses. Even the Kaisers of the world are running 3% gross margins. But what I say to people is, have you ever once gone to a hospital that wasn't building a building? Ever. The labor costs are out of control in the hospital system that we've built, and all the consolidation over the past decade, which has basically been driven by this insatiable thirst to have a pipeline of high-margin procedures, has pushed pressure down on the primary care providers. So One Medical's escaped by charging patients a little out-of-pocket fee to pay for the good customer service. But at the general provider that you'd find in LA or a big city that's been bought up by a big system, the focus is really on churning people through, increasing margins, shortening clinical visits. And as a result of that, the patient experience has gone way down. The provider's incentive in this model is to get as many referrals into high margin service lines like oncology and chronic disease as possible, and surgery, and not really to provide the best quality care for the less sort of attractive service lines like diabetes management or behavioral health. And so when we look at the system, again, our focus is on where are there specific types of care that are going to be dramatically changed by new technology, and then does that new technology give us a leverage point to disrupt the provider infrastructure? One of the interesting places you're seeing it right now that also shows some cracks in the pharma distribution model is with these companies like Hims and Nurx and Roman. Now, they've got problems, but they're essentially going to patients with direct-to-consumer pharmaceutical offerings, disintermediating the providers and the existing supply chain. We think those are really interesting hints at what the future might look like. You could see national brands across specialty care areas that would look very different than the sort of local monopolies that hospitals today represent.
And I'm curious, John, from the perspective of a very different kind of drug company, what do you think of those kind of new entrants, these companies that are sort of repackaging, rebranding these generic pills and essentially marketing these prescriptions online?
We actually really welcome them because I think that in terms of being able to bring down the costs for overall prescriptions, we think that's very helpful. In fact, the way that we think about things is how do we actually innovate so that we can change the standard of care, bring in more innovation. So let me give you a couple of examples of this, which is one in terms of you guys have been hearing about gene therapies. And we're beginning to breakthrough in terms of gene therapies. Currently, there's only one gene therapy that's approved for eye diseases, and we currently have that in Luxturna. But right now, we're in discussions with the FDA on our second gene therapy, which is for disease what we call spinal muscular atrophy. This is a single gene monogenic disease that affects the spinal column of babies. And so what happens is, this is the most common disease of babies in terms of the monogenic gene diseases. And it's in about 1 in 20,000 babies. And what happens in these babies is by the time that they're 2, they almost have it's almost 100% death. So they have about 2% chance of survival. Now what we do is we found a specific gene, it's called the SMN gene, that we actually can inject in these babies. It's called the AAV9 vector. With one injection, these babies are living normal lives. So it's kind of that breakthrough that we're beginning to see that changes the standard of care. And I can talk about many of these as the areas that we're innovating in and finding solutions for healthcare.
So I want to ask this next question to Deborah. Deborah and I were both at a panel yesterday on sort of the question of whether big companies can save healthcare. And on that panel, Bob Nelson, he's a co-founder and managing director at Arch Venture Partners, made a very provocative suggestion. And that was that he suggested that he'd love to see Google run the VA. So I wanted to give Deborah a chance to respond to that idea.
Yes, thank you. I've been waiting for a chance to respond to that. As amazing as Google may be in many areas, we truly believe that if you want to drive innovation in healthcare, you need to be partnering with the VA. And I'll tell you why. I mean, we are the largest integrated health system in the U.S., over 170 medical centers, more than 1,000 outpatient clinics. We did 58 million appointments last year. But in addition to our size, our promise is to take care of Americans' heroes from the time they're discharged from service to the time they leave this earth. And so because of that, we are passionately driven around prevention, and we are passionately driven for health outcomes and not financial reimbursement. So if you truly want to test what is going to make a difference in the health of Americans, you need to be partnering with the VA. And I think if David Feinberg were here, he would say the same thing. He would agree because he's approached us about partnering with the VA. And in addition to that, this ecosystem that we've created allows for tremendous innovation. You may not be aware that the first liver transplant was done at the VA, the first pacemaker was installed at the VA, the first electronic medical record was launched at the VA. In 2010, the VA started a program to give veterans their own data to take with them as they got care either at different VAs or in the community. About 80% of veterans get some of their care outside of the VA. We were the first organization to actually publish our opioid rates, and last year announced that we reduced them by prescribing by 40%. And last year we completely eradicated Hep C from the veteran population. So David Feinberg and what was his name from Arch Partners?
It was Bob Nelson.
Bob Nelson. Be delighted to have a follow-up conversation with Bob Nelson any day. So thank you for this opportunity to refute his remark.
So I want to direct the conversation towards the workforce and the kind of skills that the organizations, that the folks up here on this panel are thinking about in hiring. So from your perspective, Jenny, what are you looking for in providers, and how is that changing as you're sort of rethinking what a clinic visit looks like?
Yes, well, this is where I'd say we are on the modern side of things. When we recruit providers at One Medical, we're looking for really good customer service skills along with quality board certification. We're also looking to fit into a culture where the patient is really put first. We don't have medical assistants or nurses in our offices, so our doctors manage their own exam room. They are responsible to greet the patient within 2 minutes of the patient showing up at the front desk. They bring the patient back. They don't wear a white coat. They are on a first name basis with the patient. And when the patient is done with the full 30-minute visit, which is very unique for those of you who are experiencing other types of primary care where we really are trying to take care of all your needs, when the patient leaves, our clinician cleans the office, cleans the exam room. So this has created, in my mind, a really cool culture at One Medical because it's a very collaborative, very, very patient-first culture because that's what we're there for. We're solely primary care. We have no way to make money on downstream specialists, as DA was talking about. We don't do imaging. We draw your blood and send it to the lab. We barely get paid to do that, but that's a very big patient satisfier. And for all of that, we have an industry-breaking 90% net promoter score. So we're doing something focused, intentional, and very focused on the patient, and it really pays off in this area of primary care.
I'm curious to ask John the same question. How are you thinking about sort of bringing in the new types of expertise that maybe hasn't always had as sort of central a place in decision making at drug companies? So I'm talking folks like machine learning, artificial intelligence specialists, data scientists.
Sure, happy to talk. But first, Jenny, give me a application, and I'll send you my resume. Happy to apply for a role there. I think about the days of when I was treating patients, and it's actually really evolved. And when I was in the hospital, I would have my white lab coat and have various books just to give me all my reference material so that I could have all my information in front of me. Now I don't need anything but my smartphone, and I can look that information up and ensure that we have these conversations. And I think that this is the way that the evolution of how we're treating patients will evolve moving forward. And as you think about the physician, who is a big group that we actually service and look at, they are actually becoming a different group than what we have known in the past. These are physicians that are now digital natives. They grew up with their smartphones in the days of, as they look forward for information. No longer are we tied to going into all of the materials and all the laboratory information that we need in order to make these decisions. So I think that that's one piece of it is that we have all of the information in front of us. At the same time, the way that we're evolving, the way that we look at drug development is that we're also looking at individuals who have the background in the advanced sciences in terms of computer programming, understanding the digital know-how of how to do this. So we have over 1,000 scientists, and they're not necessarily grounded in terms of healthcare, but we're bringing them in and trying to work together. And I think that's the necessary integration that needs to happen as we move forward. So we have, on my team, I have a chief digital officer that helps me think about how do we look at the data and how do we actually pull together all of this information. So let me just give you, for 1 second, we have over the last 20 years, we have amassed over 2 million patient years of clinical data. We've started to pull that together in a project called Data 42. And when we started to look at it, we have, for example, one field is the sex of the patient, whether that would be male or female. We have 20 different ways of categorizing that. So just in the way that we think about how we look at our data, we're amassing all of this information so that we have a better understanding of our drugs and also use that information to better understand how we develop new molecules in terms of treatments for patients. That's the way that we're thinking about future drug development. You could see how it pulls through in terms of the way that we're going to treat the patients in the future.
So I want to ask DA, as an investor, how do you think about investing in cell gene therapy companies and sort of the different physical infrastructure that's necessary there?
Well, for one, directly to your point, the physical infrastructure to actually deliver these types of drugs doesn't exist in a lot of environments today. So you might see a proliferation of new types of providers that are from the ground up specialized around the administration of these sorts of therapies. And as you may know, the production of some of these cell therapies is incredibly complex. It involves taking blood from the patient, extracting certain selected cells, maybe processing them off-site, and all of this has to be managed through a complex supply chain with a lot of controls to ensure the safety of the products. So we think on the practical side, there's a lot to be done around the administration. On the payment and reimbursement side, there's equally as much infrastructure that needs to be built, because as we move from a chronic dosing model to a curative model that potentially only involves, as John said, giving the patient a drug one time, justifiably the manufacturers want to be paid more for a product like that, and they should be. But the way that regulators and the way that payers and the government in particular are starting to think about this is that it requires a lot more data to ensure that the value is there. So for example, with some of the next generation cancer cell therapies, there's now an effort undertaken to track the actual response in the patient over a much longer period of time, and then to key the amount reimbursed to that objective data over time to make sure that the payer is only on the hook for a $500,000 drug if it actually delivers the value that it promises. So mediating all of those sort of data collection efforts and then the payments that need to take place in relation to them demands an infrastructure that we don't yet have. That's another one of these areas where we think the next generation medicine creates a lot of disruptive opportunities on the delivery side to fund novel businesses.
And I think there are big questions about reimbursement on the primary care side as well. How are you thinking about that, Jenny, and sort of how to think about reimbursement and obtain reimbursement for this kind of care that you're providing?
Well, maybe it's an interesting data point that when One Medical was founded 11 years ago, nobody was paying for any kind of digital health, right? So that was partly why we started a membership fee, because there was no reimbursement. Today, it's pretty good reimbursement for digital health. It's not fantastic, and it's not in every state. We're in 8 markets, and so that's a tricky thing. I think we're very interested in value-based payment. We'd love to be capitated, if you will, and we'd take capitation directly from large self-insured employers. In fact, we're in many discussions with them about that, from payers. You'd be surprised that payers actually are not, at least with primary care, doing that much value-based payment, because they tend to just pay at Medicare rates and don't really want to do anything different, new and unique. And I'm not trying to bash the payers, but I don't think it's their number one priority. So that's kind of interesting. I think maybe the biggest opportunity for payment innovation is going to be with employers. We have, as we started out as a direct-to-consumer company, we now have over 3,500 employer clients in some of the largest employers in the country. And they come to us and say, be our healthcare partner. Can you work with us and develop a network or provide the primary care services and add your app and your EMR on top of that. And so I see the most innovation in payment reform coming from large self-insured employers and today, of course, it's mostly employers that are paying directly for their employees' insurances. They're not buying fully insured. So the payers are kind of shifting their attention to the fully insured Medicare, Medicaid populations, where there's more opportunity, and the employers are the ones that seem to be really innovating, at least on the primary care front.
So I think one of the most exciting and promising areas of the kind of data revolution we've talked about is precision medicine, various efforts to try to make therapeutics and care more personalized and tailored to individual patients. That's work that the VA is thinking about, particularly with the Million Veteran Program. Could you tell us about that work?
Sure. A handful of years ago, the VA started a program called the Million Veteran Program, and the goal was to get 1 million veterans to donate their genetic samples to the VA for research. We're now at 750,000 veterans participating. We're collecting over 700,000 genes in that process, and we've profiled the whole genome for about 100,000 of the participants in this database. To show you how quickly science has moved, when we first started this program, there was no thinking that this information would be relevant to an individual. This was all about research, all about finding cures, all about generating more insight. Now science has progressed to the point, Dia, we were talking about this earlier, where the information could be relevant to each of us as individual patients and to our families. And so we're starting the process of changing the consent form. The consent never even addressed this issue. Would you like to have this information back? And so now science has progressed. We have insights, and so we're changing that consent form. But so that's just a marker in time to show how the world has changed. The data is so massive, particularly when integrated with the electronic medical information that we have on these same patients, that we now have a relationship with the Department of Energy, who has the only supercomputers, in the country or maybe in the world that can process this amount of data. And we're having some internal conversations. The VA certainly never considered themselves to be a data company. I mean, not a company at all. But when you come in from the private sector and you think, oh my God, here's a gold mine, right? And how the government should be monetizing this so that taxpayers don't have to pay as much for the VA going forward. You learn very quickly that there's not really legislation and regulation that allows you to do that. So instead, we're for the first time we're recruiting a chief data scientist. We're starting to hire the same kinds of people that John has, probably teams and teams of people. And we're starting to think about this information is a national treasure, and how do we make it available to the broader research community to try to develop cures for Americans and the rest of the world, while at the same time protecting the privacy of the veterans who participate in our programs. And so it's a time of important decision making and conversation. Many of you are probably expert on this field, and so I would welcome hearing your thoughts on that. Thanks, Rebecca.
And so, of course, Novartis has been working on precision medicine since long before it was cool. John, tell me how you're thinking about sort of realizing the promise of precision medicine. What are some of the obstacles that you're hitting up against, and how are you trying to get around that?
I see a few obstacles, but many opportunities. And we started off the conversation talking about having and seeing patients in the clinic. And what I can tell you is when we were in clinic, and when I was seeing patients, what would happen is the patient would come in and the person may have heart disease, and whether that would be based on hypertension or elevated lipids, it's a trial and error approach, to be honest with you. If we had elevated cholesterol, we may try a different type of statin. And you could see many people actually rotate through the various HMG-CoA reductase inhibitors or statins, and they would figure out which one works best for them. Or it might be the situation in terms of hypertension and various blood pressure lowering drugs. Now, with the advent of all that information that you talked about that was being collected, Deborah, we actually know which ones may work better for certain patients because of all of that information and using advanced analytics. And this is not even talking about the genetics of individuals, but now we can actually say, because you're 50 years old, you potentially have comorbid conditions such as diabetes, maybe a beta blocker might be better for you in terms of hypertension, or a different type of statin or a PCSK9 might be better for you. So I think we're going to get to that personalized type of care maybe in the very near future. Now what's happened, though, advance an additional 10 or 15 years. Let's think about what we know. The Human Genome Project was started, I believe, 25 years ago. It took $2 billion to actually sequence the entire genome. Now you can actually send a sample away, and you could get it for less than $1,000. And everyone can actually get their genetics and know. And we actually are beginning to identify which ones are the mutations, and we're going to be able to treat you. So you come into the clinic 10 years from now, we actually know which mutations you have, which drugs might work best for you. And maybe it's in oncology where there's targeted therapy. We'll know which ones actually may be best instead of using chemotherapy. And you know what chemotherapy is. It actually just irradiates your entire body with chemo. So what a better way to treat patients if you know what the patient has in terms of the disease. That's where we're innovating and using personalized care to have treatments for patients and individuals.
And one aspect of that kind of umbrella of work that I'm curious to hear more about is the partnership that Novartis has with Oxford University. Tell me a little bit about that.
Yeah, so not only are we doing this alone, because we don't think we have all of the solutions, we've actually reached out to academic institutions that actually have, one, they may have the data that we don't have. So we have a lot of data, 2 million patient years, as you know, but a lot of academic institutions, happy to talk to you also, Deborah, and all the data that you have. Let's pull them all together and find ways to find solutions. So one, in terms of working with academic institutions, is we know that the information's sitting out there. Second, how do we analyze that? And the collaboration we have is what we call the collaboration with Oxford's Big Data Institute. What they're able to do is bring advanced analytic scientists that come in and actually use specific methods for us to think about how do we actually look at this data so we can find solutions for patients. And that's what we're doing with Oxford in terms of one, and I don't mean to dominate this panel, but obviously happy to talk about how we're looking at inflammatory diseases and what are the best treatments for patients that may have autoimmune diseases.
So there are a lot of companies out there that are claiming that they're using artificial intelligence, big data in new and innovative ways. I'm curious, DA, as an investor, how do you sort of sift through some of these claims to try to get a sense of what's real, what's the real deal, and what might be hype?
Sure. Well, I think the first thing is you have to, when you're analyzing one of these technology areas, create a finer grained taxonomy of what actually sits under something like what people call AI. And 10 years ago would have just called statistics. And there's a mix of hype and substance. So I think one important point I'd make around hype is that data is not equivalent to knowledge. And biology, unfortunately, is a discipline where despite how much we learn in the recent past, is sort of bereft of a lot of theory. If you think about it, theoretical physics or mathematics has a huge theoretical body behind it. And biology, for the most part, is pictures. It's people drawing pictures of how these little things interact with each other. And that's the form that our knowledge assumes. So when you are feeding an algorithm that sort of knowledge without, I guess what I would call effective theories that are able to predict the behavior of biological systems from the ground up, they're not able to find many things that we wouldn't. In other words, they find the sorts of things that we tell them to look for to a certain degree. Now, the flip side of that is that sometimes they find things and we have no idea why they're finding what they're finding. And so there's an inscrutability people will talk about with machine learning, where a really multi-layered neural network, for instance, can find clusters of data in a large set. And then if you don't know why it's finding those, it's kind of difficult to do anything with them. What we're looking for practically are very narrow applications of machine learning where we think in particular parts of the drug development cycle can be dramatically compressed. So as one example, medicinal chemistry is sort of a dark art where these geniuses sit and look at a molecule and they in their head can maybe juggle 3 or 4 parameters that they'd like to optimize. And brilliant people can indeed optimize 3 or 4 parameters, but there might be 9 or 10 other parameters that are also important in terms of the drug's potential. And so today, humans just do that in a sequential fashion. It's possible that some of these new algorithms can actually do multi-parametric optimizations very rapidly. And so you could start to see processes that take people a couple of years being compressed down to a couple of weeks. If you do that across different parts of the drug development cycle, you could imagine that companies like Novartis 10 or 15 years from now could be rolling out many more of these sort of precise drugs. Maybe they don't have as big of markets because they're targeted at narrower patient populations. But the flip side would be they could be much, much cheaper to develop and also much more efficacious for those targeted populations. So you could see their entire business model shift under the benefit of these new technologies, and that's what we're really excited about.
And John, what do you make of the characterization of traditional medicinal chemistry as a dark art?
Yeah, so usually we put these individuals in the basements of our buildings. And we don't let them out. It's like the radiologists.
It's truly dark.
Yeah, I'm just joking, obviously. But, there's some truth to that, and I think there's a couple aspects. We actually are getting more molecules than ever. in terms of looking at ways that we are advancing the way that we look at drug development. So you guys probably all know, in terms of developing drugs, you start off with looking at the various chemicals and molecular assets. And it takes about 10,000 in order for us to get to one that advances in humans. So as we look at that process, we've actually automated all of that in terms of using artificial intelligence and look at the various parameters of how chemicals are structured and how it fits into the binding sites of various receptors. That's something that we've done. The one thing that will not replace artificial intelligence is the clinical trial conduct, because I think we've only begun to understand a tiny fraction of how the human works. And the only way that we can advance that is by testing it in humans. There's no way artificial intelligence is going to overtake the clinical trial conduct, and that's where most of the time actually is spent, is the way that we actually are testing it in humans so we know what the results are. So as we conduct our clinical trials, we have many more different molecules that we can put into patients, and as we said earlier, that we have probably more solutions and more personalized solutions for patients, but the time frame to decrease that time of developing drugs and improving patient care is not changing dramatically, except by the way that we recruit patients into clinical trials, and that's the way that we think about how we advance science.
Deborah, I'm curious, how do you at the VA think about sort of what aspects of care delivery that technology can replace or augment, and what still needs to be delivered by traditional providers?
Well, it's been interesting. In the beginning, our video telehealth was primarily primary care and mental health. And it was not a physician to home, but it was physician to more remote clinic. So a veteran would come into a clinic, there would be a nurse who would be on the screen with the veteran talking to the doctor, and the doctor would ask the nurse to take blood pressure or do whatever, and so it would be kind of a facilitated video telehealth exam. Now, there are so many handheld devices that a veteran could have in their home that there's a lot more information that can be transmitted in that session. And so because of that, we've been trying to think strategically about how do we expand our footprint without building more buildings, more outpatient clinics. And so we went through an exercise almost a year ago where we mapped out where all of our veterans are and where all the VA medical centers are. And then we pinpointed where do we have the highest concentration of veterans who have to drive the greatest distance to get care. Then we overlaid the map of where Walmart had their stores across America. And we learned that 90% of Americans live within 10 miles of a Walmart. And 90% of veterans will never live within 10 miles of a VA medical center. So we are rolling out a pilot with Walmart in locations that we've agreed on together where we can address the highest concentration of veterans, where Walmart is going to designate a private room in their stores where veterans can come in and piggyback on the Walmart broadband in this rural area and have a session, a VA Video Connect session with their VA provider. And Philips, which provides some of our telehealth equipment, heard about that and said, you know, we think we could be helpful also. And so Philips is in the process of donating equipment, telehealth equipment, to 10 VSO halls in rural areas, again, where we've said we have a high concentration of veterans that have to drive a great distance. And in partnership with the VFW and American Legion, we are standing up dedicated rooms, again, for veterans in those areas to come have telehealth sessions with their physicians via video. And we think that medicine and care has moved to the point, and these handheld devices have gotten to the point where you can facilitate a fair amount of exams through video telehealth. And in some cases, it's not even by choice. We talk about a wide range of healthcare needs here on this panel. There are places that you would not consider rural, like Albuquerque, New Mexico, where there's not even a single oncologist at the VA, not even somebody who specializes in prostate or breast, but no oncologist at all. And so, you know, we have gone through the process of heroic efforts of trying to move physicians from where they want to practice to the places the VA needs them. And finally, we decided, hey, that's not working all that well. And so we are standing up specialty hubs to provide services by video. And that has included oncology, which we're standing up an oncology hub in Durham, North Carolina, where it's relatively easy to recruit oncologists from Duke, and they are serving patients in Albuquerque, New Mexico. And in New York City, we've stood up a mental health telehealth hub because there are a lot of mental health professionals in New York City. And in rural America, there may be a small number, but those may be the same people you sit next to at church or synagogue or you play softball with on your team. And you don't want to be having those kind of conversations with those people. So, Rebecca, we've been surprised, pleasantly surprised about the scope of services that we've been able to deliver by video.
And I want to bounce that same question to Jenny. How are you thinking about sort of what can be augmented or replaced by technology and what can't be?
Well, I think back to our 30-minute appointment with our patients and the primary care physician, a lot is uncovered in that meeting, and you may come in for a hurt shoulder and end up talking about your anxiety and depression. And so we believe that there will continue to be a need for an in-person relationship and a physical place to do it with a warm, friendly, trusted, compassionate person. Now, we're happy to scale up anything virtually, whatever works for people. We're happy to go with what our patients like. So it's hard to predict exactly the percentage split, but I don't think there'll be a day in the next 10 to 20 years where there'll be no physical space. And I think that anchor of that relationship is so critical to all your healthcare needs. If you do get cancer and you go to the oncologist, you can come back to the primary care physician and talk about your life going forward. And that's a very important part of healthcare that's kind of undervalued today. So it's that length of time, that important trusted relationship, and it has to be in a place that's warm and friendly and pleasant. And we have cucumber water. So, what could be better?
We don't have cucumber water.
And another question for you, Jenny. How are you thinking about sort of regulation side of things? What does that work look like and interactions look like with regulators?
Well, we're finding like-minded organizations, entities that are really pro-digital health and just really getting together and working with them. We probably haven't done as much as many organizations have, but I think putting the patient at the center, seeing what the patient wants, focusing on primary care, because today in the US, primary care has been somewhat devalued. And so we're really trying to reset that and say primary care is not only important, it's essential. And when we worry about, as DA said, all the other costs in the system, in my experience, most people don't want to go to the emergency room. They go because they don't have a good, trusted primary care physician who's available at 3 o'clock in the morning. Now, if you make that available, they don't want to go to the emergency room. In the emergency room, in their defense, they don't want those patients. Right. That's not what they're there for. They're there to take care of complex traumas and other situations. So we are just wasting money with the current system. So yes, I think that's sort of where we're coming from in all of this. And regulators, nobody is standing in our way necessarily. I think the reimbursement system is not modernized. The fee-for-service system is terrible. The reimbursement for E&M codes is terrible, honestly. It's, primary care doctors compared to surgeons are underpaid. We're losing them, and that's a really scary thought. It's difficult to train them, and so we're really focused not only on recruiting them, finding the best, we're also focused on making their lives pleasant. So we use artificial intelligence to really take work off the doctor. How do we use natural language processing to route messaging and do things for them so that our goal is that they can leave work at the end of the day and do no more work at home? And that is, I see a lot of heads nodding, that's a really big task because most EMRs do not make that possible. We have our own homegrown EMR. We're releasing code every day. The code is about what the doctor wants to be the best doctor they can be, to be that warm, personable, compassionate person. So it's all these things together, and it takes all of that to make it really work well.
So at this point, I want to open up the floor to questions from the audience. I'll ask folks if you have a question to raise your hand and wait to speak with the microphone. And it would be great if you could also just briefly say your name and which organization you're with.
You hear me now? I'm Jay Walker. I'm with TEDMed. John, I heard you say something, but I'm sure I didn't hear it right. You were talking about a gender classification, and you said there were 42 varieties?
20.
20 in gender classification alone in
That's
the
right.
data.
That's right. In the way
Human
that we
gender,
collect.
we're talking.
Human gender. That's right. It's surprising, isn't it? And
I heard it, and I thought I heard it wrong. but
you
I
know,
didn't.
what we found in terms of when we're looking at our own data is that it is, you would think that it would be very easy to look at our data and say, well, how do we actually categorize this information? It is so hard because there are so many different ways of looking at whether it's gender, demographics of patients, what the age they are. Sometimes we actually collect the actual age. Sometimes we use cutoffs. For labs, sometimes we actually use different parameters, whether that would be called SPGT or AST is another way that we do it. There are so many different ways. And that's actually been the difficult part of actually analyzing the information. So we've gotten past that part. We've spent a year collating that information, and now we're beginning to advance and beginning to do the analytics. So you would think that the analytics part is harder, but it's not harder. Actually, we find that to be the easy part. It's getting all of that data so that you can actually use it. That's the hard part for us so far.
And to follow up on that question, what are the kinds of sort of hiring or kinds of projects you're prioritizing in order to organize that data in a way that's ready for you to analyze productively?
Yeah, there's three ways that we look at the data and the way that we're advancing in terms of digital technology. One is actually gathering insights for us so that we have a better understanding of the new drugs that we develop, or in terms of the drugs that are currently in the marketplace so that we have a better way of serving the patients. That's number one. Second, the way we look at the data is so that we can improve the end-to-end patient experience. And that's really what we're striving for, is so that we can recruit the patients. We know how we actually want to use wearables, digital devices. That's the end-to-end patient experience that we're looking at. And third is the underlying processes that we're trying to improve. And the underlying processes, as you were talking about, and you asked the question to Jenny about regulators, what we find is that we've actually advanced so fast that the regulators have not caught up. So I talked about decentralized clinical trials, going out and recruiting patients out in the various communities so we can have collection of information. They want to know that, because the way that we look at clinical trials, we use the form what we call 1572s to make sure that the investigator is a validated investigator so that the data that we collect is validated. Now you go out to the patient and you say, okay, we're going to collect data from the patients. The regulators are saying, how do we know that data is actually validated? And we say, well, we don't know that. And they say, well, without having the validation, we can't accept your information. So now begins the tension that begins to play out. So I would say the third is putting together an infrastructure for how we actually improve the processes for filing and ensuring that we can work with the various regulatory agencies. That's the way we think about data and digital.
Let's get another question from the audience.
Yeah, following up on that, it appears that the one thing that is absolutely clear is you're going to generate a lot more data and you're going to be trying to manage a lot more data. Was sort of surprised to hear you've gone to the Department of Energy for use of their supercomputers. What is your plan going forward on where you're going to store all this and how you're going to manage all of this data?
Google's going to do that. aren't they?
I think we're still discussing that. I mean, honestly, there is such a sense of stewardship at the VA about privacy and veteran data, and a lot swirling around in the media about lack of privacy, right? That I think the VA is one of the last organizations to start moving data to the cloud and trying to figure out how to do that effectively. these are really important questions that we're grappling with right now. So I don't have good answers for you at the moment, but happy to come back on that.
There's a different infrastructure for various companies that are doing that. A lot of us are actually moving to the cloud, as someone said earlier. And there's a couple of major services that obviously you could see where competition is fierce in this area. Amazon Web Services is one, Microsoft has another, and there's a third service. Those are the three predominant ones that we've been looking at. I would say there's no one that's preferred over the other currently, but we currently are assessing which ones. But you know, the key to that is storing it so that you're not that you can actually move from one cloud to the other, right? Because otherwise you're locked in for eternity that you're going to be, you put this up in the cloud, whether it's Amazon Web Services, sorry if anyone's working for them. But you don't want to be locked in for eternity because then forever you're going to need that information. So you want to be able to have it where it's flexible and agile to move into the various cloud platforms, and that's the way we're looking at it.
I just want to add, too, that my point of view on this is that patients should own their data. You know, when you're on Facebook, you are working for Facebook. That business is built off of your contributions to their enormous data set. And to the extent that patients on-the-ground lived reality data becomes the feedstock of pharmaceutical value creation, the patients should participate in that. And in fact, we have the technology at our disposal today to make that possible. So I like the idea of thinking of data living in a marketplace where the patients are not cut out of it the second they leave the hospital. And then again, it's the hospital who's trying to monetize their data. We've looked at some blockchain-related technologies that could mediate that. They don't need to be decentralized, but decentralization is an interesting paradigm for managing that sort of data because this is a sort of data that we'd like to sort of live in a commons. In other words, it'd be best if Novartis weren't the only company to have my data. I'd like the whole world to be able to benefit from my personal biological data. And so how could you get all of these different stakeholders to work on one platform? Amazon's never going to do that. The world will be fragmented into these silos. And so we're interested in whether there can be a single sort of decentralized marketplace that everyone is excited to participate and contribute to.
And John, what do you make of DA's argument?
Yeah, I think we don't want to own everyone's data either. We want the individuals to actually own their own data. We just want to use it so that it is for the better good of improving healthcare. That's the intent. There's no intent for us to say we need to own all of the data. In fact, we think that would not be serving the needs of the community and what the healthcare community wants.
Let's go. One last question from the audience.
Thank you. Terrific panel. Thanks for bringing up the patient at the end. My name's Kelly Close from the Diatribe Foundation. I was curious, you know, I love the idea of the patients being excited and engaged in wanting their data. And I'm wondering how you think about that in many of these diseases where the patient populations are pretty heterogeneous. How do you think about it from institutional perspectives? How do you think about it in terms of designing the molecules? And then how do you think about it in terms of funding entrepreneurs?
Well, I mean,
Go ahead. No, I was just going to say, at the VA, we started an initiative in 2010 called the Blue Button, and the idea is that the veterans own their own data. And since 2010, we have been adding more and more information to that as it's been possible to do. Immunizations, MRIs, you know, everything that we can put on it, we believe it's their data. And since they go back and forth between the VA and the community, it's in their interest and our interest to have the full picture of what's happening in their lives. The big change for us in the past year was we made that data available through Apple and their healthcare app. But we're an open platform. We're on API now, as opposed to in the past when we were creating our own proprietary systems. And so we're eager to partner with other organizations that can add value to patients and their own information.
I would just add that, you know, my starting point as a patient, not as a physician or as someone who came out of pharma, is that the patients are the most underutilized resource in the healthcare system. So I like to talk about the amount of time that the average dad will put into choosing a barbecue. You know, they will read thousands of reviews, they'll go test them out, and then the most significant thing ever in their life happens. They get cancer, they get heart disease, and they go into the doctor, and in 15 minutes someone tells them what they should do, and they just go, okay. And this paternalism is so deeply baked into the system that we've got to figure out how to leverage patients' own creativity. Now, you know, doctors get tired of so-called Dr. Google and people coming in with crazy, you know, I want to do juices and Reiki and whatever. Some of that may be promising ultimately, but you know, there's another community that I see, particularly in some of these narrow patient populations, where you've got, like, look at the ApoE4 people. I mean, if you go on these message boards on the internet, these folks are trying things and thinking about pharmaceutical concepts that are years ahead of industry. And so if we can figure out how to leverage that broad-based creativity and intelligence among patients, I think they can be a real resource for the entire industry.
Do either of you want to address that
Nothing
question?
to add. That's great.
Great. Well, thank you to the audience for some great questions, and thank you to our panelists for a great discussion.
Thank you.
Thank you.